Circulation. In the absence of breathing despite a clear airway, chest compressions should be commenced immediately. Chest compressions should not be delayed by palpating for a pulse, but should be commenced immediately in the absence of breathing and continued until the cardiac rhythm can be checked and cardiac output confirmed. Hand position should be over the center of the chest, and it is important to ensure that the direction of compression is perpendicular to the chest wall, thus the angle of tilt must be taken into account. Compressions should be performed at a ratio of 30:2 ventilations unless the woman is intubated, in which case chest compressions and ventilations should be desynchronized, with compressions being performed at a rate of 100 per minute and ventilations at a rate of 10 per minute. Because chest compressions are not as effective after 20 weeks of gestation, there should be early recourse to delivery of the fetus and placenta if CPR is not effective. 2 wide-bore cannulae should be inserted as soon as possible. There should be an aggressive approach to volume. Hemorrhage is the most common cause of maternal collapse and a consequence of other causes of collapse. There must be a high index of suspicion for bleeding and awareness of the limitations of clinical signs. Caution must be exercised in the presence of severe preeclampsia and eclampsia, where fluid overload can contribute to poor outcome. In the case where both significant hemorrhage and preeclampsia and eclampsia exist, careful fluid management is essential. Abdominal ultrasound by a skilled operator can assist in the diagnosis of concealed hemorrhage. Very occasionally, ultrasound by a skilled operator can aid diagnosis in cases of massive abruption and intra-abdominal bleeding, although laparotomy should not be delayed if the findings are negative or the index of suspicion is high. However, this should not interfere with the resuscitation process. The same defibrillation energy levels should be used as in the non-pregnant patient. If defibrillation is required, the same settings should be used as in the non-pregnant patient, as there is no change in thoracic impedance. Adhesive defibrillator pads are preferable to defibrillator paddles, and the left defibrillation pad should be applied lateral to the left breast. The energy from the defibrillation shock is directed across the heart, and there is no evidence that shocks from a direct current defibrillator have an adverse effect on the fetus. Uterine monitors should be removed before shock delivery. Drugs. There should normally be no alteration in algorithm drugs or doses. Common, reversible causes of maternal cardiopulmonary arrest should be considered throughout the resuscitation process. Throughout the resuscitation process, consideration should be given to the cause of the collapse so that the continuing therapy can be directed towards the specific cause to optimize outcome. Resuscitation efforts should be continued until a decision is taken by the consultant obstetrician and consultant anesthetist in consensus with the cardiac arrest team. When, where, and how should perimortem cesarean section be performed? If there is no response to correctly performed CPR within 4 minutes of maternal collapse, or if resuscitation is continued beyond this in women beyond 20 weeks of gestation, delivery should be undertaken to assist maternal resuscitation. This should be achieved within 5 minutes of the collapse. The rationale for this time scale is that the pregnant woman becomes hypoxic more quickly than the non-pregnant women, and irreversible brain damage can ensue within 4 to 6 minutes. The gravid uterus impairs venous return and reduces cardiac output, secondary to aortocaval compression. Delivery of the fetus and placenta reduces oxygen consumption, improves venous return and cardiac output, facilitates chest compressions, and makes ventilation easier. It also allows the heart to be compressed easily through the diaphragm against the chest wall by placing the hand behind the heart with the diaphragm closed and compressing it against the posterior aspect of the anterior chest wall. This improves cardiac output beyond that achieved with closed chest compressions. Before 20 weeks of gestation, there is no proven benefit from delivery of the fetus and placenta. Perimortem cesarean section should be considered a resuscitative procedure to be performed primarily in the interests of maternal, not fetal survival. Delivery within 5 minutes of maternal collapse improves the chances of survival for the baby, but this is not the reason for delivery. If maternal resuscitation continues beyond 4 minutes of the collapse, delivery of the fetus and placenta should be performed as soon as possible to aid this, even if the fetus is already dead. There is, of course, the possibility that the outcome could be that of a severely damaged surviving child, but the interests of the mother must come first. Perimortem cesarean section should not be delayed by moving the women. It should be performed where resuscitation is taking place. Time should not be wasted by moving the women to an operating theater. A perimortem cesarean section can be performed anywhere, with a scalpel being the only essential equipment required. With no circulation, blood loss is minimal and no anesthetic is required. If resuscitation is successful following delivery, there should be prompt transfer to an appropriate environment at that point, as well as anesthesia and sedation to control ensuing hemorrhage and complete the operation. If resuscitation is successful following delivery, there should be prompt transfer to an appropriate environment at that point, as well as anesthesia and sedation to control ensuing hemorrhage and complete the operation. The doctrine of the best interests of the patient would apply to conduct of this procedure being carried out without consent. The operator should use the incision that will facilitate the most rapid access. In terms of the best incision to use, a midline abdominal incision and a classic uterine incision will give the most rapid access, but many will be unfamiliar with this approach, and as delivery can be achieved rapidly with a transverse approach, the operator should use the approach they are most comfortable with. If resuscitation is successful, the uterus and abdomen should be closed in the usual way to control blood loss and minimize the risk of infection. Where the outcome is not successful, the case should be discussed with a coroner or procurator fiscal to determine whether a postmortem is required before any medical devices such as lines and endotracheal tubes are removed as per the Royal College of Pathologists' recommendations. A perimortem cesarean section tray should be available on the resuscitation trolley in all areas where maternal collapse may occur, including the accident and emergency department. To ensure there are no delays in executing a perimortem cesarean section when indicated, the equipment necessary should be immediately available on the resuscitation trolley. All that is required is a fixed blade scalpel and 2 clamps for the cord. In the absence of a specific tray, a scalpel alone will enable delivery of the fetus and placenta and cutting the cord, which can then be manually compressed until a clamp is found if the baby is alive. What does the continuing management consist of? Senior staff with appropriate experience should be involved at an early stage. Transfer should be supervised by an adequately skilled team with appropriate equipment. This would usually mean transfer to a high dependency or critical care area with appropriate staff and monitoring facilities. Hemorrhage. In the case of maternal collapse secondary to antepartum hemorrhage, the fetus and placenta should be delivered promptly to allow control of the hemorrhage. In the case of massive placental abruption, cesarean section may occasionally be indicated even if the fetus is dead to allow rapid control of the hemorrhage. Venous thromboembolism. The specific management of massive pulmonary embolism is covered in the RCOG Green Top Guideline number 28, Thromboembolic Disease in Pregnancy and the Puerperium Acute Management. Amniotic fluid embolism. The management of amniotic fluid embolism is supportive rather than specific, as there is no proven effective therapy. Early involvement of a senior experienced staff, including obstetrician, anesthetist, hematologist, and intensivist, is essential to optimize outcome. On top of resuscitation and supportive measures, arrhythmias may develop and will require standard treatment. Inotropic support is likely to be needed, and measurement of cardiac output may help direct therapy and avoid fluid overload, as this will exacerbate pulmonary edema and increases the risk of acute respiratory distress syndrome. High feeling pressures are indicative of a failing left ventricle. On top of resuscitation and supportive measures, arrhythmias may develop and will require standard treatment. Inotropic support is likely to be needed, and measurement of cardiac output may help direct therapy and avoid fluid overload, as this will exacerbate pulmonary edema and increases the risk of acute respiratory distress syndrome. High feeling pressures are indicative of a failing left ventricle. Coagulopathy needs early, aggressive treatment, including aggressive use of fresh frozen plasma. If undelivered, delivery of the fetus and placenta should be performed as soon as possible. The incidence of uterine atony is increased in this condition and contributes to the postpartum hemorrhage. Cardiac disease. After successful resuscitation, cardiac cases should be managed by an expert cardiology team. After initial resuscitation, the continuing management of cardiac disease is similar to that in the non-pregnant state, although in many cases, delivery will be necessary to facilitate this. Although thrombolysis can be associated with significant bleeding from the placental site, it should be given to women with acute coronary insufficiency, although caution should be exercised in the perioperative period. If available, percutaneous angioplasty allows accurate diagnosis and definitive therapy. Sepsis. Septic shock should be managed in accordance with the Surviving Sepsis Campaign guidelines. The speed and appropriateness of therapy administered in the initial hours after severe sepsis develops are likely to influence outcome, with early resuscitation improving survival rates. A multidisciplinary team approach is required, including midwives, consultant obstetricians, consultant anesthetist, consultant hematologist, consultant intensivist, and consultant microbiologist. The following care bundle should be applied immediately or within 6 hours and has been shown to significantly improve survival rates. Measure serum lactate. Obtain blood cultures or culture swabs prior to antibiotic administration. Administer broad-spectrum antibiotic or antibiotics within the first hour of recognition of severe sepsis and septic shock according to local protocol. In the event of hypotension and/or lactate greater than 4 millimoles per liter, deliver an initial minimum of 20 milliliters per kilogram of crystalloid or colloid. Once adequate volume replacement has been achieved, a vasopressor such as norepinephrine and epinephrine and/or an inotrope, for example dobutamine, may be used to maintain mean arterial pressure over 65 millimeters of mercury. Further management consists of, in the event of hypotension despite fluid resuscitation, septic shock, and/or lactate over 4 millimoles per liter, achieve a central venous pressure of at least 8 millimeters of mercury or over 12 millimeters of mercury if the woman is mechanically ventilated with aggressive fluid replacement, and consider steroids. Maintain oxygen saturation with facial oxygen. Consider transfusion if hemoglobin is below 7 grams per deciliter. Continuing management involves continued supportive therapy, removing the septic focus, administration of blood products if required, and thromboprophylaxis. Drug overdose or toxicity. Many drug overdoses have specific therapy dependent on the drug in question, and appropriate help should be sought in the management of such cases. In obstetric practice, the two main drugs that can give rise to overdose or toxic problems are magnesium sulfate and local anesthetic agents. Magnesium sulfate. The antidote to magnesium toxicity is 10 ml, 10% calcium gluconate given by slow intravenous injection. Local anesthetic agents. If local anesthetic toxicity is suspected, stop injecting immediately. Lipid rescue should be used in cases of collapse secondary to local anesthetic toxicity. Intralipid 20% should be available in all maternity units. Treatment of cardiac arrest with lipid emulsion consists of an intravenous bolus injection of intralipid 20%, 1.5 milliliter kilogram over 1 minute, 100 ml for a 70 kilogram woman, followed by an intravenous infusion of intralipid 20% at 0.25 milliliter kilogram minute, 400 milliliters over 20 minutes for a 70 kilogram woman. The bolus injection can be repeated twice at a 5-minute intervals. If an adequate circulation has not been restored, a further 2 boluses of 100 milliliters at a 5-minute intervals for a 70 kilogram woman. After another 5 minutes, the infusion rate should be increased to 0.5 milliliters kilogram minute if adequate circulation has not been restored. CPR should be continued throughout this process until an adequate circulation has been restored, and this may take over an hour. Manage arrhythmias as usual, recognizing that they may be very refractory to treatment. Prolonged resuscitation may be necessary, and it may be appropriate to consider other options. The first-line treatment should be lipid emulsion, but if the facilities are available, some may consider the use of cardiopulmonary bypass. All cases of lipid rescue should be reported to the National Patient Safety Agency and to the lipid rescue site. ECLAMPSIA. Eclampsia should be managed in accordance with the RCOG Green Top Guideline number 10A, the management of severe preeclampsia and or eclampsia. Intracranial hemorrhage. Expert neuroradiology is required to establish an accurate diagnosis. Management is the same as in the non-pregnant state, although delivery may be necessary to facilitate this. The appropriate experts should be involved at the earliest opportunity. Anaphylaxis. In cases of anaphylaxis, all potential causative agents should be removed and the A, B, C, D, E approach followed. If the anaphylactic reaction occurs in the community, the woman should receive basic life support and be transferred to a hospital setting as quickly as possible. Unless a suitably trained healthcare professional is present with appropriate equipment or drugs, in which case definitive resuscitation and treatment should be commenced. The definitive treatment for anaphylaxis is 500 micrograms, 0.5 ml of 1:1000 adrenaline intramuscularly. Please note this dose is for intramuscular use only. Adrenaline treatment can be repeated after 5 minutes if there is no effect. In experienced hands, it can be given intravenously as a 50 microgram bolus, 0.5 ml of 1:10,000 solution. Adjuvant therapy consists of clopeniramine, 10 mg, and hydrocortisone, 200 mg. Both are given intramuscularly or by slow intravenous injection. What are the outcomes for mother and baby? Owing to the lack of robust population data, it is not possible to be accurate regarding outcomes. For some conditions, such as the amniotic fluid embolism or AFE, the maternal survival figures are more robust, but accurate data collection is required for maternal collapse as a whole. Who should be on the team? In addition to the general arrest team, there should be a senior midwife, an obstetrician, and an obstetric anesthetist included in the team in cases of maternal collapse. If the maternity unit is an integral part of a general hospital, the maternal cardiopulmonary resuscitation team should be the hospital cardiopulmonary arrest team with the addition of a senior midwife, the most senior resident obstetrician, usually ST 3 to 7, a resident anesthetist who has recognized skills in obstetric anesthesia, usually ST 3 to 7. While managing the arrest, there must be a dialogue between the team leader, the obstetrician, and the obstetric anesthetist as to how best to manage the pregnant women. In standalone consultant lead maternity units, or those that are geographically distant from the main general hospital, the entire arrest team is often made up of staff from within the maternity unit. In this case, the team is usually made up of senior midwifery staff, operating department practitioners, resident obstetric staff, and the resident obstetric anesthetist. The consultant obstetrician and consultant obstetric anesthetist should be summoned at the time of the cardiopulmonary arrest call. The neonatal team should be called early if delivery is likely, antepartum collapse over 22 weeks of gestation. Where the woman survives, a consultant intensivist should be involved as soon as possible. Clinical governance, documentation. Accurate documentation in all cases of maternal collapse, whether or not resuscitation is successful, is essential. Poor documentation remains a problem in all aspects of medicine and can have potential medico-legal consequences. Contemporaneous note-keeping is difficult in a resuscitation situation unless someone is scribing. Those involved should then write full notes as soon as possible after the event. Incident reporting. All cases of maternal collapse should generate a clinical incident form, and the care should be reviewed through the clinical governance process. Maternal collapse is a rare and potentially devastating event, and substandard care continues to be highlighted. In all cases of maternal collapse, care should be reviewed to ensure individual and organizational learning, and also to reassure staff and the family when care has been optimal. In view of the significant reduction in maternal mortality over the years, robust population-based data regarding maternal collapse through a national reporting system would render valuable information about management and outcomes. All cases of maternal death should be reported to CMACE or Center for Maternal and Child Inquiry. Training. All generic life support training should make mention of the adaptation of CPR in the pregnant women. All frontline staff must be aware of the adaptations for CPR in pregnancy. This includes paramedics who will deal with collapse in the community setting and accident and emergency department personnel, as well as staff within a maternity unit. All maternity staff should have annual formal training in generic life support and the management of maternal collapse. The Royal College of Obstetricians and Gynecologists, the Royal College of Midwives, and the Confidential Inquiry into Maternal and Child Health recommend that all staff undergo annual training in obstetric emergencies. Life support training reduces morbidity and mortality. Small group interactive practical training is recommended. A systematic review of life support training showed a significant reduction in morbidity and mortality, and there is now a wealth of evidence emerging to show that multidisciplinary training in obstetric emergencies improves outcomes. The elements of multi-professional training of all staff and integrating teamwork training with clinical teaching are important. The ideal frequency of training is not clear, but this should occur at least annually for all staff. Debriefing. Debriefing is recommended for the woman, her family, and the staff involved in the event. Maternal collapse can be associated with post-traumatic stress disorder, postnatal depression, and tocophobia. Family and staff members should not be forgotten. Debriefing is an important part of holistic maternity care and should be offered by a competent professional. Appendix number 1. Post-collapse management algorithm. Appendix number 2. Maternal collapse algorithm.